this not started, Sherry? Oh, I cannot believe we just did that. Apologize, folks, for the delay. After doing this for 8 years, somehow I forgot to click on the start button to get us going. So I've just cost us 4 minutes. I apologize for that. I was talking to you, but I didn't realize you didn't hear us. So I'll let everyone get situated. For those of you joining us, this is Bright Spots in Healthcare, and this is Eric Glazer, your host and your moderator. Our show is produced by Shared Purpose Connect, and each episode we bring leaders together to not only inform our audience, but also unearth bright spots, success stories at health plans, at health systems and hospitals and other healthcare related organizations around the country. Our goal each episode is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared with you today are able to be applied at your organization. We believe that this approach of finding a bright spot, identifying it, and then cloning it is the most effective strategy to improving healthcare significantly in our lifetime. And I have said that a number of times, including just a few moments ago, and I'm sure my panel is really impressed that I could do it verbatim a second time. I encourage you all, if you have not already, to go onto your phone or your tablet and use whatever podcast app you use and search Bright Spots in Healthcare, and make sure you subscribe. So each and every episode gets automatically downloaded to your device. So if you can't attend live, you can get all the great content and listen to it on your commute to work or your walk every day or wherever and whenever you have time to listen to really good professional educational content. I believe the leaders that we bring on this show can have a real great impact on your business. A huge shout out and thanks to our sponsor today. We can't do this without our sponsors. Insignia Health is on the show today and is supporting today's episode. If you have not heard of them, check them out in insigniahealth.com. You'll definitely have heard of what they do and the platform they represent. First of all, they develop tools and technologies that assess and support patient activation to improve patient care across our industry. Their foundational offering is called the Patient Activation Measure, or PAM, as many of you know it as. Their clients include small organizations called the Centers for Medicare and Medicaid Services here in the US and National Health Services over in England. There are few organizations who have spent as much time studying patient activation across multiple verticals as Insignia. Their verticals include hospital health systems, health plans, and insurers, pharma companies, and governments all over the world. Really excited to have Chris here today representing Insignia, and we'll benefit from his insights and experiences as we talk about how consumer data and activation will drive future profitability in healthcare. Check them out at insigniahealth.com. We are bypassing interviews to save time. Sherry's going to post for you a link that will have information on every single one of our 5 esteemed panelists, so you can learn more about them as they start talking and as I lob them over questions. I've met with all of them ahead of time. They have incredible stories to share, so I'm excited to jump right into it right now. We'll start with Chris Delaney. He's the CEO of Insignia Health. And Chris, start us off by talking about the science and methodology behind patient activation. And maybe if you could help define the difference between activation and engagement. Go ahead.
You bet. Let me kind of start with why measure activation. The journey with PAM, or the Patient Activation Measure, began a good 17, 18 years ago in academia, with this kind of belief that there is no greater impact on premature death or illness burden than the choices, the behavior of individuals. And in fact, if you go beyond kind of the direct impact, we have the indirect of, some people can overcome determinants of health, access to care issues, even genotype, phenotype, right? So the realization was that it matters perhaps more than anything if we're going to bend the cost curve, improve outcomes, reduce preventable utilization. We need to kind of tap into kind of the power of the individual to be really more successful at managing their health and healthcare. And this led to the development of PAM, or the Patient Activation Measure, in academia, and then brought it out as a company. It has been studied and published on 710 times, journals across the world. It is a 10-item assessment that measures really kind of the roots of a tree. Think of it as knowledge, skills, and confidence. But if you nurture these roots, all the things kind of above the root line, utilization, outcomes, and so on, can be strengthened, can improve. 10 items found in EMRs like Epic, care management software. Eric mentioned a direct contract with CMS. PAM has been integrated into alternative payment models, both as a prom, but also to guide support. So a really unique opportunity to have activation, self-manageability at the point of care as a prom, but also being used to guide support. So think of it as kind of a three-fer, right? We target, we tailor, we measure impact over time. So 3 applications, 10 items, administer it 2 or 3 times a year with an individual. Think of it also as kind of a vital sign, right? This is the patient self-management or patient activation vital sign. Now, compared to engagement, we hear that a lot. We think about engagement. We have an engagement measure. I tend to view engagement as transitory, episodic. You can come in, you can come out. It's important to activation, but what we really focus on is the sustained journey, helping somebody kind of master the skills that sustain, that last, that lead to resiliency, that leads to problem-solving abilities. As we take somebody up what is kind of a 4 activation level continuum on a 100-point scale. And that 100-point scale is like the measures in the natural sciences. We know the value of a point change, which doesn't exist very often in healthcare surveys. So a 1-point change, we know, for instance, was worth a 2% decline in hospitalization across a population. It allows it to interact and predict other equal interval measures like ED visits, A1C, admits, readmits, and so on. So let me stop there. I know a whirlwind quick tour of measuring activation and a little bit on how it compares, contrasts to engagement.
Thanks, Chris. So I want to transition now, and we're going to spend the vast majority of the remainder of our time on storytelling. And we're going to have a bunch of interesting stories about how AI, predictive analytics are driving more effective communication and activation. Quick PSA, to provide us feedback in about 45 minutes, you'll get another email from me. I know, a lot of emails from Eric Glazer, with a feedback survey. It's literally 2 minutes. Our regulars know it's really quick. We always ask you different questions about our performance, our content, and what we should be doing in the future. So thank you in advance for providing us that feedback. Also, we have a Q&A module, which I'll be monitoring along with our producer, Sherry Keels, and we can integrate some of your questions into our conversation today. So I'm going to start with Kiana Moore. She's the Director of Market Strategy and Analysis at an organization called Alliance for Community Health Plans. Kiana, why don't you start and tell us an example of how one of your members is using AI or language processing or any kind of predictive algorithms to drive more effective activation. And actually, before you start with your story, just a quick sentence or two on ACHP so people know where you're coming from on this.
Sure, Eric, thanks for having me. ACHP, we're a membership organization, and we're made up mostly of fully integrated or provider-aligned nonprofit health plans. And together we aim to improve the health of communities we serve and actively lead to transformation of healthcare to promote high quality, affordable, and equitable care with superior outcomes. So to answer your question, one of our member organizations that comes to mind is UPMC, and there are 2 great examples. They partner with Estrada to use real-time natural language processing monitoring platform to help close HEDIS gaps. So first, focusing on a HEDIS measure that identifies older women with bone fractures who've yet to receive appropriate imaging or intervention for osteoporosis. They were able to identify and screen these candidates earlier. Typically, they have to use health claims, but with NLP, they were able to read provider notes and then identify the need for intervention within hours of the fracture occurring. So they were able to have representatives reach out to the members to get early screening. That's one great example that comes to mind. Another quick one is another UPMC company, Realize Intelligence, and they use NLP and artificial intelligence to pinpoint optimal treatments for chronic disease and for cancer patients. So what the platform does is it reads through EHR data and it picks out a cohort of patients with precise conditions to be able to elevate them for priority attention, if you will, so to get earlier appointments. Additionally, it allows for a more holistic view of the patient by analyzing so much of the rich information that's embedded in clinical notes. We all understand the importance of total person care, and patients aren't really what their primary diagnosis is. So AI can improve a better understanding of the patient story. And it's a great way for the healthcare community to build trust with consumers and provide better patient experience. And lastly, if I could just wrap up, again, AI is great, but it's really important to make sure that we prevent these technologies or algorithms from exacerbating racial inequalities. And there's no silver bullet here, but there is a lot of great work that's being done. Some organizations are controlling for bias by setting artificial standards in the algorithm to overemphasize some of these disadvantaged groups and de-emphasize others. And it also goes without saying that more diverse teams and awareness helps, because bias can be introduced throughout the system, not just in data collection, and it has this trickle-down effect that needs to be addressed at every step.
Do you have any sense, and I may be putting you over your skis here, on how UPMC was able to integrate these two programs into the clinical workflow? Often some of these doctors and nurses have so many different things thrown at them. Do you have any sense of the adoption and how hard or difficult it was for UPMC to take these programs and make it smooth for their providers?
Yeah, sure. I would say, without getting too far over my skis, they have a really close working relationship, the health plan and the provider system. And so again, I think it starts from the top and the leadership. And so collectively, they work together to figure out how you introduce it into the work stream so that it doesn't necessarily create additional work. It's reimagining the work, if you will. So providing the prompts at the time that's necessary. And so it took a fair amount of sort of change management to reimagine what the workflows needed to be.
Great. Next storyteller I'm going to bring in is Todd Howard. He's the Associate Vice President, I believe, of Data Science, Todd, at Humana. So Todd, could you provide us an example of how Humana is leading an initiative around data collection and then of course activation?
Yeah, Eric, no, appreciate that. And I'll say that, at Humana, we're in the middle of we're in the process of digitally transforming ourselves. So in terms of using more elements of the cloud, for example, kind of an exciting development that we've been doing lately is integrating more voice data and transcription into our customer experience. And so what that means is that, just to kind of contextualize that, whenever you call in, for example, and then into our call centers, naturally, we're monitoring those calls for quality. But what we're trying to do now, and this is all enabled by the cloud, and is that we're able to transcribe the calls. That means just literally taking the voice, the words that are spoken and turning it into text initially, and then using that, we're able to layer on elements of AI that allow us to create kind of a more personalized view of what that call was about. And really what's beautiful about that is, historically, we would have basically had to listen to those calls, right? So it's a very manual process. So imagine, we're getting, 100,000 calls in a day, just as an example, and we want to know what's hot today, right? What are things that we're seeing on the ecosphere? And, being able to take that voice, turn it into words, and then layering on the AI to both highlight topics that are important to that day, so that we can help address them, kind of be more proactive about addressing them for people who are calling the next day, but also being able to start to personalize, our member experiences, right? So historically in healthcare, it was very, very transactional. I think we mentioned, the use of claims, for example, to find out where members are in their health journey. This is starting to allow us to provide rich context around the member experience. So not only do we know that, you're visiting the doctor, but we're starting to see elements of where we can use natural language processing and also this voice and transcripts to say, what's the context around the member's experience, right? When you call in, you say, hey, not only do we know you called in, you're talking about your physician visit or something you have a question about, we're also able to extrapolate that to say, okay, in your care journey, we can say this call can be related to this set of claims. And that allows us really to create a more personalized customer experience and really leverage the cloud and AI to say, not just for the members that call in, but how many other members like you that have called in, what was their experience? And realistically, how can we, or, in a practical sense, how can we make sure that we're layering on solutions to make your experience better by that, essentially for that silent majority, by using AI to say, hey, this is what worked. Can we make that next call that is about that topic be just as effective?
Todd, what are just like if there was 3 pillars on how to get this moving forward, what are like the 3 key ingredients for those listening that they need to be aware of if they were going to build this or lead an initiative like this at their organization?
Yeah, so assuming that you're already kind of recording the calls, right? And this is something that all of us do. It's very standard now in the industry. The first thing you'd want to do is obviously line up a transcription partner. There's a lot of commercial offerings, that you can use. So essentially, you just need to turn that voice into text, which is essentially pumping oil out of the ground and kind of getting it to the first stage of the refinery. The next piece is for us is layering. We have an AI platform. We call it the machine learning platform, and essentially, it's a way that allows us to kind of take that raw text and start using different types of algorithms. Again, natural language processing is kind of the first step on that, but essentially getting our data scientists to go in there and say what topics are hot, what elements in there are we looking for, and then the last piece is kind of there's an integration layer, right? If you ever came to me and you asked me about an AI project or whatever, my first question is going to be what do you care about? My second question would be how would you use it if I could tell you everything that you care that you want to know? And really have a clear plan on that integration strategy so that you can turn the voice into text. You have the AI, which essentially is generating those insights. But a lot of times, just make sure you have a plan to say, like if you're a dog that caught a car, so to speak, make sure you know how those insights will be taken into action, because that'll help refine the answer to say, hey, I see you boiled the ocean. You gave us these top issues, but what you really care about are levels 2s and 3s. And the data scientists need to hear that so that they can surface the right insights that ultimately enable, however you're going to activate it, your campaign strategy. You want to make sure your call center folks can have the right information at their fingertips to have that actionable insight that again generates that personalized experience for your customers.
So transcription, AI, action, sort of communication.
Yeah, integration. Yeah, integration is probably the way to say it. Mm-hmm.
Got it. Perfect. Thank you. I'm going to bring in now Dr. Brian Miller. He's a family doctor by training. He serves as the Chief Medical Informatics Officer and VP of Telehealth at Promedica in Ohio. So Brian, why don't you tell us a little bit of an example of how this is being applied at Promedica?
Yeah, actually, Eric, I think it might help to understand kind of who we are really briefly. We're a healthcare organization. We have a lot of hospitals. We have a lot of practices and providers, multi-specialties. We have a payer arm, and then uniquely, a lot of organizations like that. Uniquely, we also have a big post-acute space, senior care, with skilled nursing facilities, et cetera. So, and we're, I don't know, from a size standpoint, I think now that makes us about the top 20. We're in Northwest Ohio in our footprint, nationally in our senior care space. I did kind of love that Kiana slipped in her, feels like it slipped in her mission statement. I'm going to give you a quick one on ours in that too. It's your health is our mission and purpose. Purpose is a new addition. I think Eric's diving into that in a podcast that's coming up soon. So that was my teaser and a commercial for you, Eric, because purpose is big here, and you're talking to our guys about that, and it's a really interesting thing. So tune in for that one as well. So the story I'm going to start with is around our sepsis and deterioration scoring. So on our inpatient side, our sepsis and deterioration piece is a proprietary AI-based predictive modeling program that comes from our EMR vendor. And really what it's designed to do is really help us alert our inpatient clinicians around patients that are taking a downturn, either into just generalized deterioration or into full-blown sepsis. From a data standpoint, that tool uses well over 300, almost 350 really very discrete clinical data elements. And when the algorithm kicks it up and it's appropriate, it pushes very specific alerts up to our clinicians, to our bedside clinicians, the nursing staff, and also to the docs on that care team, that either a deterioration or sepsis might be underway in that particular patient. It's a way to say, heads up, providers, focus here and do that focus right now because things are happening fast right here. And also embedded into that, and this is an important component to the tool, is a decision support piece around what do you do about it? What's our response to that? We're not just saying, hey, take a look. We're also teeing up for them, if you feel like it's appropriate, we're going to let you trigger the alert team to the bedside to jump right on that patient. We're going to let you trigger the order set, that evidence-based order set we have around our sepsis protocol orders. This whole thing is really about speeding up how we identify deterioration of sepsis and then responding to it. Because in sepsis, in deterioration, but especially in sepsis, every hour of delay from the time it starts to happen to the time you start recognize and intervene, most studies say that's around a 4 to 5% drop in mortality every single hour in that patient. So, our stroke docs, say time is brain, but here time is life. And so time does equal save lives. So from an ROI standpoint, obviously for us, saving lives is the biggest ROI. But when you start to look at the more objective ROIs here, our numbers have varied. When we look at it, we've had this tool for about 3 or 4 years now. And we have also had to change the settings overall. And there's some interesting pieces to that, because it's not just turn it on and it starts to deliver. The settings really matter. And if we have time, we'll talk about that. And then our numbers have also been very much changed since COVID. We have to look before and after. COVID changed everybody's metrics. But in general, I can tell you, we're at about, depending on the quarter we look at, we're at maybe a 5 to 10% decrease in mortality, small day and a half, maybe 2 days of decreased ICU stays. Patients don't get as sick. They don't have to be in the ICU as long. And some organizations are doing better than that with this tool. We're seeing some organizations deliver 20 and we're trying to deliver that, but even 5 or 10, up to 10, those are really big numbers, because tiny increments here mean really big dollars saved from the payer standpoint. So the payers, we really think, care about this. We care about it because it saves lives, but it also significantly reduces cost, because a very sick patient stays in the hospital a long time, and the ICU stays are so expensive now. Little increments here really matter on the cost side.
That's great. And it's actually, that's huge money, right? Huge money.
Huge money.
You said ICU reduction around 10%. I mean, that's right.
Yeah.
That's massive. You also teed up our next panelist perfectly, because I want to talk a little bit about using this approach for better impact around COVID. So to do that, we'll bring up Colleen Murphy. She is on the West Coast, up a little bit bright and early for us. She's the Network and Strategy Officer at Health Plan of San Mateo. So come on in, Colleen.
Thanks, Eric. And I feel like I have about 10 million questions for all of our former panelists about all of those stories. So I will try to keep this story a little bit brief. I know we've got a lot of great ones to cover. So Health Plan of San Mateo, we're actually a county organized health system. So that means that we are the sole payer for Medicaid for our county. It means a lot of other really cool things about our kind of partnership with our county health department that I can't say enough about. But really what I wanted to talk about today was just how we try to use data to really promote vaccine access for folks who needed it the most. So we kind of flash back to February of this year, which feels like about 10 years ago, I think. But we were coming out of the surge here in California and really just looking to plan for vaccine rollout as the eligibility criteria expanded. So we built a risk algorithm to help us to do that. We knew that there was movement towards making availability of the vaccine for high-risk folks, and so brought in our medical directors to kind of pull together a list of medical conditions and disability status that correlated to higher morbidity or mortality for COVID. But then also to Kiana's earlier point about really making sure that we're directing resources to account for disparities and really focus on folks who might be at higher risk of negative health outcomes. We also used race, ethnicity, and geography data locally to kind of adjust that algorithm up. And so taking a look at stats around higher prevalence, morbidity, or mortality for subpopulations in certain zip codes of certain race and ethnicity identification, and then also pulling in some information about homelessness status. All of that goes into the machine here, and then we came out with a risk stratification of 1 to 7, and really used that to do two things. One, kind of focusing in on that highest risk group, we tried to find who's the person most engaged with folks' care. So if we had someone on first, a care coordinator, someone like one of our local CBOs who really was heavily engaged in care, we made sure to give them a chase list of their folks who were going to be eligible sooner, and provide them with a lot of materials to go have those conversations about vaccine availability. For everyone else who wasn't connected to care with a dedicated case manager, that was really then on the plan or in partnership with our county health folks. So did a lot of outreach, phone calls, a lot of mailings, and really set up a couple of dedicated vaccination events that were just for those folks who are in our highest risk tiers when the vaccine was still limited in its availability. What we've seen kind of come out of that so far. So right now our plan rates are just hovering an inch over 70% of folks who've been partially or fully vaccinated who are eligible. But for those highest risk tiers, so for 1 through 3, that number is 78 to 88% vaccinated. And so we really kind of see that pay off in being able to get folks in early.
So Colleen, just for context here, you're dealing mostly with CAID and dual eligibles, a lot of ESL members as well, correct?
We are. We cover about 110,000 Medicaid lives as well as about 10,000 duals. And we have a separate county-run program that covers folks who wouldn't be eligible for Medicaid, largely our residents who are undocumented.
Great. I want to switch gears a little bit, not a little bit, but not switch gears per se, but I want to transition a little bit of our dialogue now into activation programs themselves. And so let's talk about those hard to engage members right now. And Chris, how do you go about thinking about activating the consumer who is traditionally harder to engage, a la like Colleen's membership?
Yeah, probably kind of our sweet spot is thinking about how do we kind of help the hardest to engage, people that maybe historically have been thought to be intractable, realize progress when it comes to self-management. Typically, if you think about our model, it's 4 activation levels. About 45% of a Medicaid population is in the lower 2 PAM levels, similar for Medicare, somewhere between 45 and 50%. They tend to account for 85% of all the things that we're seeking to improve, right? So they're unbelievably important to higher quality and improved outcomes in everything that exists in value-based care. If you think about value-based care, like performance measures, 50 to 60% in every model I've looked at isn't tick box or isn't tied to the care delivery side. It's tied to what the patient does over time. So we really have to be successful with those that are low in activation. We think about interacting in kind of a unique way in that we have to meet them where they're at, not just say it, but actually do it. So we use PAM levels from this 10-item survey to identify them, and then to kind of think about helping them learn to swim. In healthcare, there's such urgency, limited clinical interactions, short duration. We throw everyone into the deep end of the pool, right? You have high blood sugar, you have to do this, this, and this, or else. Here's the brochure, here's the flyer, here's the website, here's the phone number. And that's overwhelming for those who are used to failure, the low activated. So thinking about how do we help them learn to swim? They're clinging on to the shallow end of the pool for dear life. But the great news is that they gain the most in every country we operate in, clearly capable of increasing. They tend to move up a level in 6 months, 2 levels in 12 months. And so meet them where they're at. Think about integrated interdisciplinary care teams, clinical, non-clinical. A really great example of that is actually San Mateo on the care delivery on the system side, where California has this kind of Medi-Cal program, a whole person care program. San Mateo on the delivery side created this kind of Bridges to Wellness program focused on the most challenged individuals within their Medicaid program, multi-morbid, housing insecurity, mental health conditions, and really created this clinical, non-clinical team, interdisciplinary, to work with them, tailored to PAM levels, identified risk more effectively. And in their earliest evaluation that we have, that they were really kind enough to share and to allow us to publish, 18% decline in ED, 50+% decline in inpatient. So off to a great start. And so I think it's a good example, though, again, the greatest gains often come in populations that are struggling the most. And although we work across the continuum of plan types and types of patients, we really kind of love to help those that are really struggling kind of realize that I can do this, and help them build resiliency and build this self-management competency that can last over time.
It's a really good example. I know that you guys have had a case study written up on this. So I think it would make sense if those of you who are listening, if you kind of want to, and I think it's like a one pager. I reviewed it earlier this week on that case study around San Mateo County Health. I'll have Sherry put up a poll, and you guys could request a copy of it. We'll send it to you, so you don't have to, log in anywhere or anything like that to get it. It's a quick read and really outlines nicely, even in some more detail, the story that Chris just said. I think this is a good quick segue. One of the things, obviously for us to keep this podcast going, this is our 8th year doing it. We have to find organizations that are they're not only willing to sponsor, but we really want to pick organizations that provide expertise in the area of the areas that we want to provide content to all of you. And so got to know Insignia over this past year. They've been a partner of ours throughout the year. And there's just very few organizations that have been working on patient activation research and platform development as long as they have. So just a quick little reminder of who they are, a plug if you've joined if you joined us late. They've been consulting in this area for over 20 years, and they provide solutions around patient activation assessment, as well as patient health coaching and engagement resources. So they have the whole kind of package. They're working with every vertical you can imagine, from pharma, health plan, health system. They're working, the clients include CMS and NHS, as I said earlier. We know as folks in this industry that in order to improve a consumer's health, we have to meet them where they are. And the patient activation measure, that PAM platform, it's a 10 or 13 item survey, and it measures a patient's current knowledge, their skills and confidence to manage their own health and healthcare. And it allows you, and the design and results are validated by hundreds and hundreds of studies. It's the oldest one out there, the most validated one out there from around the world. So if you really want to be able to apply some of those principles to augment what you're trying to do at your organization, I suggest you reach out to them, even as a sounding board, to pick their brain for ideas. Even if you don't want to hire them, I suggest you reach out to them, and you could check them out more at insigniahealth.com. I want to get into a few more examples of programs. So I want to talk about how we can incorporate the progressive use of data into effective activation programs. So Kiana, could you come back in? You have this luxury of having a membership of companies from all over the country, and maybe provide us with another example, but one that sort of focuses on that activation part.
Sure, absolutely. And again, I can't underscore Chris's point about really understanding and addressing barriers to care if we really want to activate the consumer. So another plan that comes to mind that I think is a really good example is Priority Health in Michigan. They partnered with Socially Determined, Aunt Bertha, and Costesano to create this data-driven, full life cycle approach to addressing social determinants and improving health outcomes. And essentially what they did was leverage consumer data as well as these partnerships to proactively identify social risk among their members, and then initiate culturally resonant engagement, and then connecting people with critical resources to address the needs. And they're looking to use this in a repeatable way. It's still very early in the process, but they've done a really great job at being able to pinpoint where the biggest needs are so that they can direct their resources toward the most impactful programs across their memberships, by specifically identifying individuals in need of target interventions. Again, regardless of whether they had a recent touch point or not with a healthcare provider or some other social service. Again, this is sort of the beauty of data. And they've been able to gain visibility into some of the social risk for their populations and their communities. And then so having access to this information is so critical for being able to identify and again, target some of these interventions and resources. Another really, really important part is the partnership around really being able to engage them in a culturally and linguistically aligned way that really gets at addressing some of these problems in underserved communities.
Great, thank you. It's actually a good segue. I actually didn't put two and two together when I planned out the line of questions here, but I want to bring Brian back into the conversation. Brian's boss, Randy Ustra, actually introduced me to Socially Determined initially way back when they were just getting started, and they've actually, I think, invested in that company. So it's a nice little segue. Yeah. Talk to me a little bit, Brian, about how you're doing similar efforts in engaging the underserved.
Yeah, Randy was a very an early proponent of social determinants as a really important thing that we were not addressing well in healthcare. He started us on that journey a decade ago. I mean, it's a hot topic now, but he was way ahead of that curve. That's a really great long story that I'm going to try and make short here. But we're at a point now where across our business lines, those 4 big business lines I laid out, we actually screen, depending on the business line, between 10 to 14 total domains of SDOH. And a lot of orgs will screen 2 or 3. We're in most settings around 14 domains. So that's about 120,000 screens every single year. So we are very much identifying and going after it. So I'm going to focus on this part of the story on around 40 to 50,000 screens in our provider setting, mostly in our primary care. So what we do, and yeah, this is the socially determined connection. They function as a data analytics company for us, but they also essentially host our clean room. And what they ingest from us is a giant pipe of all our clinical data, which is well over 1 million patients. And they take our clinical data out of our EMR. They take payer data, they take claims data out of our payer side, and they also take some claims data out of our claims that we get because we're an ACO network. They also take our screening data and they crunch all those things together. So we provide a lot of interventions because we have so many domains of screen. We also have an entire team called the Care Hub, which is functionally, I guess, for the audience, it's a care nav team that's focused only on our SDOH identified needs. And these are all screenings. So these are self-identified by the patients. And then we administer interventions. With food, we connect you to food, housing, we connect you to housing, et cetera. And so socially determined takes all that data into a warehouse, and they patient match, and they bump that data up against the claims, and they look at pre and post intervention. And what they're helping us identify is, okay, we know that part of our mission is to identify that we need to help. We need to help people who can't eat find food. We need to help people underhoused to get housing. And there's certainly mission in that, but is there ROI? And they help us identify what happens to those claims downstream and help prove ROI. So I'm going to just give you 2 quick examples. Our food impact analysis in our Medicare population alone, what we've seen is an almost 20% reduction in ED utilization when we connect people who I've self-identified as food insecure and we connect them to food. We've seen about a 5% reduction in their admissions and readmissions, and we've seen somewhere between a 6 and 10% in their total per member per year medical costs. So for us, we look at that and we go, yeah, it's not, our point is it's not a philanthropic effort at this point. We're not just helping people eat, we're actually helping the healthcare society here, our industry, reduce our total costs. Our financial impact opportunity as well. We identify financial need. I'm just going to give you one more set of numbers because we're really proud of these. We clearly make a difference in their once we coach them and identify the need. We've seen an average on everyone that we coach. We've seen their average monthly income go up around on average $610 a month. That's a significant number of dollars. We've seen their credit score go up almost 40 points, which is a big improvement in their credit score. But on the medical side, we've seen a 10% reduction in their ED utilization and an almost 40% reduction in their inpatient stays. So we're improving their financial health, we're improving their medical health, and the evidence of that is reduced medical costs. Wow. So there's an ROI in SDOH intervention, and that's our point.
That sounds like a whole nother episode I want to do. It's awesome. If you're scoring at home, folks, I think we're up to like 7 now stories and bright spot examples. So this could be a record for our show here. So there's a few more coming. We're going to come back to ROI and the business of all this even more. Brian kind of teased it up. He actually went into it a little bit, but we're going to talk a little bit more about it later on. But before we jump to it, I want to talk about the provider. We haven't really focused on how the provider fits in this entire process and what we could do to incentivize the provider to help us activate patients, collect data, and activate patients. So I'm going to bring in back Colleen Murphy, aka Murph, to talk a little bit about what they're doing with their providers.
Great, thanks, Eric. So this is a topic I get very passionate and poetic about, so I will try to, again, restrain myself in the interest of time, but we really see our role as a health plan kind of, in three places. We have the data, we have the dollars, and we have the ability to connect folks across a really disparate healthcare system. And so kind of how we use those tools to really impact the healthcare of our community is really heavily dependent on really engaging our providers. And just the one example I had a chance to share a little bit about with Eric, I wanted to kind of highlight today is our value-based payment playbook. So we have, like many plans, moved towards more value-based payment for our provider network. And the details of kind of what measures we use and kind of how we weight everything is probably a lot less interesting here. I think the thing that I want to really share that's been meaningful for us and a bright spot for our plan has been working with our providers in a really collaborative way to define that program, and then trying to actually work with them to provide the tools so that they can do well within that program. So a few components of that. One is that as we've rolled out value-based payment programs for our primary care network, and then more recently for our skilled nursing facility network, and now we're working with our hospitals, we've really brought those providers in to help us inform the design of the program, the measures that are selected, and really the way that we're going to do data sharing together. So that is almost a year-long process of getting a lot of feedback from the network. Second kind of component of success here is just a ton of data sharing. Again, there are lots of ways to do this in more exciting ways, but we are, to start with at least, sharing a lot of data back with providers on a monthly and sometimes weekly basis on those care gaps and kind of just performance and how they're doing within the program. But then the piece that's maybe a little bit more unique is how do we actually engage with providers to make sure that they actually understand that. If we're really just relying on data and dollars to change healthcare, we're going to set ourselves up for failure and probably have some risks of inducing harm. And so it's been important for us to really have providers engaged in understanding what those reports are. How does that actually change the behavior of the front office staff who's scheduling someone to come in? How does that actually change the behavior of the provider, making sure that they have what they need to really close those care gaps for their panel? So the third component of all of this is just a lot of ongoing training and engagement with those providers on a local level. So providing them with resources and the tools that they need to do well in that program.
Colleen, how do you, could you dive into, and I don't know if you have purview into the rabbit hole that I'm about to go into or want to go into, but how do you connect the incentives and extra payments to the doctors and whatever training involved in making sure that they're covering that, and the data collection to make sure that to monitor their progress in that tied to the actual results? Is it all tied towards what the government's going to provide and you're giving them almost a draw against that, or the plan is? Help balance the numbers for us a bit.
Yeah, so one example of this, it's a simple example, so I think it helps to illustrate the point a little bit, is how we incentivize access. So when you have a primary care network who is capitated, there's going to be an incentive built into that for underutilization. And so really making sure that we have put some real dollars, actually up to 30% of reimbursement, towards making sure that our providers are actually engaging with their panel every year. That does a couple of things. We need to actually have evidence that that touch happened. And so it does help us improve our data collection. And it also really helps us, again, to balance the kind of built-in incentive that you might have for having just a pure numerator denominator HEDIS measure as a dollar incentive. We want to make sure that we're really getting folks in to be seen, and that we have the data and claims to support that the touch happened.
That's great. And how much effort and resources need to be put forth to communicate to your provider network that you're actually doing these things? I mean, I'm sure, obviously action speaks louder than words, but some of those actions may go behind the scenes that they don't realize that you're working behind the scenes. Are you out there marketing to them and communicating to them all the stuff that you're investing in enabling them to be successful? And how important is that?
We are, and I would say this is we are unique in being a very small plan. So we are the smallest health plan in California. We are very local. We are, tied in lockstep with our county health partners. So we have a much smaller network than many plans, but we really have found that kind of broad, scalable digital communication does not do the trick. We need folks out there actually meeting with our providers in person. Over COVID, that's of course been by teams. That is really the kind of the secret sauce there, I think, has been quarterly engagement with the full network, and then individual coaching and follow-up to really make sure they understand the tools that we provide.
That's great. All right, so that's a good transition to the business, and I'll bring Todd back into here. He's been on the bench for a little bit. We got to get him limbered up and back out here. Todd, talk to us a little bit about how Humana's bottom line is benefiting from these investments in data collection and activation. If there's an example that you could provide us.
Yeah, thanks, Eric. So, broad strokes, we put a lot of intentionality into reaching out to our members. And one of the things that we talked about in terms of making that personalized experience isn't just that we make the messaging, like we would say, like before mass blast type campaigns, things like that. Now through that personalization that from these passive channels that we're collecting, using that transcription, other types of member context, we're able to have more targeted campaigns so that instead of outreach into 6 million people with an email or a marketing campaign, we're able to kind of have more, hey, what's your preference in the channel? So we're contacting people where they want to be contacted.
It's great. And how about, and what does that do? Like what's the end game there? I mean, does that improve member retention? Like what's the pot of gold?
Yeah, no. I think that, it definitely improves our response, right? So all of our marketing our investment in our marketing dollars and other types of campaigns becomes way more efficient. So, definitely, that's definitely like a benefit to being able to use this to kind of create those more personalized options. And I think that the responsiveness and like the customer experience is also, optimized in that case. For example, before, obviously we have millions of outreaches we do a year, and we can really provide contextualized campaigns that are focused down to the individual member experience, as opposed to like historically we would have more like department focused experiences. So say, we might have our clinical folks with a campaign, and then our member retention folks with a campaign, et cetera. We're starting to able to get like a horizontal member experience that we can put together using these insights. And again, you just think about reducing 10 outreaches to millions of people down, even if you cut it in half, there could be some there are like real material savings in that from just an operating expense perspective.
Okay, so I'm hearing that there's some gains on just operational efficiency and less, we'll call it waste. Do you also look at, okay, if we're engaging the individual on a day, based upon the claims and transactional data, does that correlate to people actually staying in the plan? And do you have a process or a platform that's set up so you could measure that on an ongoing basis?
Yeah, I would say that, we definitely, so we use like a test and learn type methodology, right? So this is where to help kind of focus our different efforts. So, kind of going back to AI, element, basically in a more scientific kind of way, we try to set up like tests and controls to say, here's 2 members and we're going to try to influence this person to stay in the plan, for example, versus somebody would kind of do like the normal run of the day kind of business. So yeah, we're starting to see, a lot of really meaningful results in using those personalized campaigns. And again, to say, for what we know the member, how they want us to contact them, right? We want to follow those preferences, those channels, and that would result, again, ultimately results in an experience where, hey, we're meeting the member where they live, so to speak, as opposed to where we might historically have just wanted to contact them just because we happen to have, a phone call bank ready, but we know that maybe the member wants to be engaged digitally. That's where we're really turning the corner on how we engage those members, and ultimately that experience, leads to better outcomes. Both in just like more tactical outcomes in terms of like immediate NPS and other types of benefits, and then long-term outcomes from reducing churn for members staying in the plan.
Great, thanks. I know, Brian, you had mentioned the ROI of that underserved program. It was pretty powerful with the ICU reduction and things of the like. Do you guys as an organization take a more macro approach to measuring the impact and the risk reward of being so aggressively proactive in the spend?
Yeah. Yes. Yeah, although and I know I kind of scooped myself in the RI piece. There's actually one number I would like to clarify because I think it actually really lights it up. So in that population, when we did the food intervention when there was a hunger issue, we saw a 6% reduction in medical costs in those patients, and that's year over year from before and after the intervention. It's important to compare those to people who actually didn't actually engage with a food intervention. And in that population, we saw a 7% increase in per member per year. So the delta for food was actually a 13% reduction, depending on what would have happened if you hadn't or if you did. So that is a big number of dollars in a Medicare population. So the delta is important as well there. So yes, Eric, from a proactive standpoint, that is really, I think, kind of our next horizon. SDOH is really important. Obviously, now that we're starting to show that there is cost reduction involved very specifically with certain interventions, we'd like to be a little more targeted in how we apply those interventions and push those interventions deeper into the populations that we know we have needed. And although we do a ton of screens, we also know we're barely scratching the surface. And a lot of patients who have the deepest SDOH need are patients we don't actually probably get in our clinics. And if we don't actually get them to the office, we don't have a chance to screen them because that's how our process is. So our next level is to use Socially Determined, our data analytics partner, to start to identify based on demographic data, based on publicly available data, based on proprietary data, using an algorithm and AI, identify populations where we know there's a high likelihood. We may not be seeing them, but patient A, B, and C in our data banks are really likely to have a food need or a housing need or a financial need. And to proactively reach out, just suspect that they have those needs, and to reach out and identify that need and then potentially connect them depending on how they answer that question. And so what we're doing is starting to tee up populations, and we're actually tying it to clinical course. So we already know that our payers really care about SDOH, and we're making an argument around cost reduction, but we know they already care about really specific high cost chronic disease states, the ones we always talk about: diabetes, COPD, CHF, et cetera. So we'd like to identify patients who have those that were already costing a lot of money because they have a chronic disease. And on top of them, and they're usually seeing specialists and we're not screening. On top of that, if they have an SDOH need, that SDOH need is very likely to substantially amplify that cost. We know that COPD patients with a housing need, if they're in bad housing and they have bad air, they're going to have a lot more flares. So we're going to chase those people. So we have the proprietary algorithm to go after that. That's so cutting edge, Eric. Our compliance department first said, "Nah, you can't actually reach out to people like that." And the honest truth was it was right. And up until this year, we needed some CMS policy changes and some legislative changes to allow us to use data in a way that we could more proactively go after that. So starting this year, we're allowed to do that because they've taken a little bit of the handcuffs off. And I think we're going to make a bigger difference in a bigger set of populations.
That's great. That's great. It's actually a tee up for our last question. So Chris, I'm going to let you take us home here. And Brian did a really nice job without even knowing it, setting you up. There's a question from one of our audience members around, is it the collection of the right data or valuable actionable data? And with all the data that we have coming in, how do we differentiate between all of that and make sure that we're focusing on the right data?
Yeah, so I think there's kind of two things that come to mind. So first, lots of terrific dialogue around ways to identify risk and different elements of kind of the risk mosaic for a patient, for a person. I think one of the challenges that we have is having the insight, then the so what. So, do you then have a model that takes that insight and closes those gaps? And I think when we think about activation, we measure the risk, but we also know how to shift that risk and reduce it and improve activation. So, we're fortunate in that we have a risk model, but also the tools, the intervention, the training that is designed to actually mitigate that risk. Think about traditional risk models. They look backwards, claims data, clinical data. They're not particularly strong prospectively. They tend to have R-squareds of 0.25, 0.28, 0.20. So they miss 7 or 8 out of 10 high risk individuals, but they do find very costly people. And then we focus on that. We tend to think more about, but you missed 70 or 80%. And so it kind of takes me to, and I've grown fond of kind of the Moneyball analogy. Oakland A's, Billy Beane, baseball was recruiting players and thinking about a traditional set of data metrics. He came in and said, well, but these probably aren't the right metrics. We have different data that's also there that we're going to use to, and it ended up being a paradigm shift in the game of baseball, to better identify players at risk. His famous quote, one of them was to someone that liked the old school model. Well, if you're identifying, good hitters, how come they're not hitting well? Well, I think that's kind of the challenge that we face with traditional risk models. We know in published research looking against the most licensed risk model from a certain big company that it misses 60% of patients in the lower 2 PAM levels. And so, as you might imagine, we advocate for an added layer, if nothing else, of understand self-management ability, understand activation as another layer, another lens, because it's a prospective lens. We're not looking backward, but we know definitively where someone's headed if they score low. And in my perfect world, I can't imagine a scenario in which you tell me someone's a level 1 or a level 2 managing diabetes, heart disease, and I look at the past utilization, the past risk model, and I say, but they haven't used a lot of care. They're okay. Heck no. I just don't need that past insight to focus prospectively on these individuals that are low in activation. Now, might I use the retrospective risk model to add that layer of urgency? Like, okay, level 1's high risk score, right? Level 2's high risk score. So I could triage. But I think we have to, and this has come up in all these really good examples, think more broadly, more rigorously about how to identify risk. But then also, then what? Then what do you do? How do you close the gaps? And can we arrive at systematic approaches and models that solve and don't just tell us about the risk? And that's I think where we have to figure out that next money ball. I think we're starting to crack the code around activation, but there is a future kind of example around paradigm shifts in engagement, or as we like to think about it, sustained engagement, which is activation.
The Billy Bean of healthcare, Chris Delaney. So guys, we're at the top of the hour. I want to thank everyone who has joined us. We never take for granted the hour that you have in your day and how busy you are and your roles at your organization. So we appreciate the time, whether you're listening to us live or listening to us by way of the podcast. To our esteemed panel, thank you for all the work you've put into preparing with me and for your inputs today live on the show. We really appreciate it. This will mark the end of the episode. We have another great episode on behavioral design next week, live recording Thursday, 12 p.m. East Coast time. So make sure you go to sharedpurposeconnect.com and register for that for free. This will mark the end of today's episode. Until our next episode, find that bright spot and clone it. Thank you very much, everyone.
Thank you.